there we go. Okay. We'll just give Sarah a couple of seconds. And then, well, welcome everybody to the fourth and last session of the European Association for Behaviour Analysis Summer School. We are delighted today to have Dr. Zoe Lucock with us, who is going to talk to you about the behaviour analysis, aging and major neurocognitive disorder. Zoe is a BCBAD and a UKSBA cert with a passion for working with older adults, including those with and without intellectual disability. She has a particular interest in major neurocognitive disorder like dementia, in common language, including how to understand this disorder from a behaviour analytic perspective and the implications it has for clinical decision making. Zoe completed her PhD in behavioural gerontology at Bangor University and went on to found the UK's first service provision for older adults with dementia. Alongside her role working with adults with intellectual disabilities within the NHS, she runs her private practice, Enrich Behavioural Gerontology, and I really recommend that you have a look at that. There's some fantastic educational videos and talks provided by Zoe under that title, Enrich Behavioural Gerontology. Maybe we can share the link during the chat. She's providing clinical services, supervision and continuing education training in behavioural gerontology. Zoe has been the chair for the EABA Behavioural Gerontology Special Interest Group since 2021, and her publications in behavioural gerontology can be found in the Journal of Applied Behaviour Analysis, Behaviour Analysis in Practice, Behaviour Analysis Research and Practice, and Behavioural Interventions. A regular presenter at behavioural conferences across the globe, such as EABA and UKSBA, Zoe has presented on a variety of topics relating to older adults with learning disability and dementia, ethical issues in behavioural gerontology, assessments with older adults with dementia, and interventions working with older adults living in their own homes. It's an absolute pleasure to work with Zoe today. She's also been teaching at Queen's University for a number of years, so we've known each other for a while. It's just fantastic to welcome you today to our summer school, and thank you so much for agreeing to talk. I'm going to pop out here and let you talk. For anybody who has questions to Zoe, please use the little questions icon at the bottom of your screen so that all the questions can be filtered through that, so that Zoe will be speaking for about 50 minutes and then there will be time for questioning. So over to you, Zoe. I'll see you at the end of the talk.
Thank you so much, Carola, and thank you, of course, for inviting me. I will always take any opportunity I can to talk about behavioural gerontology. So I will get started. Like I say, just pop those questions in there. I don't know if I'm going to be able to keep track of the chat, so I will look at the questions at the end. I did also make a little poll if anybody wants to answer that, just about why people are here. What's your experience of behavioural gerontology? Is it an area that you work in? Are you interested in it, but you don't work in that area, or are you just here out of curiosity? So I've just popped that up, see why people are here, what their motivation is. But I'll get started. So today, what I'd really like to talk about with you is the context of working with the older adult population. I want to give you a little bit of an idea about the background and what's happening in the world with older adults, the definition of behavioural gerontology and where it began. It might surprise you. I want to talk about how we understand aging from a behavioural perspective and also major neurocognitive disorder. We'll see that's, you probably know that as dementia from a behavioural perspective. And then I want to give you just a few examples of where behavioural gerontologists have worked with older adults with dementia on different areas. So maintenance of skills, engagement, teaching new skills, and reducing distress behaviours. And then at the end, I'm going to talk a bit about the difference between working with older adults versus other populations that behavioural analysts often work with. And I'll finish by talking about older adults with intellectual disabilities and dementia, particularly those with Down syndrome, and how we as behavioural analysts can adapt our practice to support those individuals. So I've got loads to get through and I can talk forever on this topic. So I'm going to try and keep myself in check. So just so you know a little bit about who I am, I know Carola's given you a great introduction, but as I say, I'm Zoe. I originally thought I wanted to work with kids. I thought kids were amazing, definitely no other population for me. And then I started working with kids with autism, and yeah, the kids were lovely, but I wasn't in love with behavior analysis with kids. I love behavior analysis and I loved kids in general, but I just, those two together just wasn't where I was meant to be. So I went back and retrained, did my PhD in behavioural gerontology, defended that during COVID, and then went on to establish the UK's first provision in behavioural gerontology for older adults with dementia. I currently work in the NHS, so our National Health Service in the UK, working with adults with what we call learning disabilities, what the rest of the world calls intellectual disabilities. And I work with people who are really high risk of being detained under the Mental Health Act, so sectioned, being arrested, people who are likely to be served notice on where they're living, suicidal behaviours, often with people with additional mental health diagnoses like schizophrenia, sometimes dementia, and personality disorder, and just generally people who have had a significant amount of trauma in their life. So I really like a challenge. I like really complex cases that are a bit tricky to work on. Those cases that you get them and you go, I have no idea what I'm going to do here. So those tend to be my cases. And as Carola said, I'm the director for Enriched Behavioural Gerontology. I won't go on about that. And I'm also the chair for BGSIG, which I will plug for again at the end. So I wanted to start off, when I was thinking about writing this presentation, I wanted to start off by talking about groups that behaviour analysts may or often work with, particularly minority groups. So when we think about minority groups like individuals with learning disabilities or intellectual disabilities, this is a minority group that faces significant prejudice and stereotypes and discrimination in day-to-day life. Most behaviour analysts work with people who are neurodivergent, and again, people who are neurodivergent, we know experience more higher levels of discrimination, of prejudice in their day-to-day life. The same goes with people with physical disabilities, and also those from ethnic minority backgrounds, people who are Black. And I wanted to, and obviously other minority ethnic groups, but I wanted to think about, I'm never going to experience what it's like to be someone who doesn't have white privilege. I have white privilege, I've always had it. That shapes the way that it changes the way that people interact with me, the contingencies that I experience in my life. I'm never going to experience what it's like to have an intellectual disability, because I don't have one now, and you have to have one as a child. It has to be developmental. I'm maybe, but probably never going to be physically disabled. And I don't think I'm ever going to experience what it's like to be neurodivergent, because I'm not. So I'm never going to experience those groups directly, and they experiences they have. But older adults, that's a group I hope to be in one day. Older adults are another minority group that are discriminated against, that experience prejudice in society, where we hold lots of stereotypes. But I think they're unusual in that we all hope to be part of that group one day. And that, I feel, makes them a little bit different to other groups that we might encounter. Because despite the fact that we all want to be there one day, because the alternative is that we've not made it to older adulthood, we still treat older adults as a culture, especially in westernized culture, we still discriminate against this group. And they are a group that we often don't realise we're discriminated against. And I wanted to give a few examples of this. So despite the fact that we all want to be there, older adults still experience a really significant amount of discrimination. And ageism, which is obviously discrimination against somebody because of their age, is so pervasive in our society. And I think it's one of the forms of discrimination that most of us don't realise is happening, and it's still really socially acceptable. It does disproportionately affect women, but I thought I'd give you a few kind of just examples, like all these things you see beauty products all the time looking at fighting visible signs of aging. The idea that if you look like you are aging, then that is a bad thing and you need to fight against it. How to reverse your looking like an older person. Joking about people being old. I don't know if you've seen, like, I'd rather be over the hill than under it. all these things, we use phrases in our everyday language. We compliment people saying, oh, are you that age? You don't look your age. Or we insult people by saying, I don't know if this is a UK specific phrase, but we say, oh, she's mutton dressed as lamb, i.e. she's an older person who is dressing as a younger person. That's seen as an insult. If we do something wrong, you go, oh God, I'm getting old. It's the old age. We talk about maybe having a senior moment, or we say we can't teach an old dog new tricks. So this idea that older adults are less than is really, really embedded in our verbal behaviour. It's embedded in our culture. Now, the reason why I'm sharing this is because to start to understand older adults, you also have to understand this context, and that you're coming to somebody, say a client that you're working with, who has been subject to this messaging throughout their entire lives. We all have. That's part of our culture, at least in my culture. And those rules, those stereotypes, that verbal behaviour is something that often gets internalized. That becomes private verbal behaviour. Therefore, it can become a self-fulfilling prophecy. If you think you are not as good at things as you get older, you're less likely to try because you think you're not going to be able to do it because you're old. You're less likely to want to do things or think you're capable. You're less likely to, all these things are because of our internalized ageism. We've got these preconceived notions of what it means to be old. So when I come to an older adult, not only am I looking at all the behavioral stuff that I want to look at, but I'm also coming to a lifetime of stereotyping. I'm coming to a learning history of rule-governed behaviours, not only in that person's behaviour about themselves, but also in the staff or the carers or the family's behaviour, but also in my own as well. So I have to be mindful and combat my own ageist opinions, stereotypes, biases that I've had conditioned throughout my lifetime. So I just want you to hold that in your mind as we go through today. And if nothing else, take that message away around the fact that this is a group that also experiences discrimination. It's just one that we tend to see as acceptable. And if we're working with that population, we need to take that into account. So I want to talk a little bit about aging and our life expectancy. So the life expectancy of humans around the world is getting bigger. We are living longer and longer. And that is a great thing. It means that we are healthier. It means that we've got better healthcare, better science, better prevention, and people are living longer. Fantastic. Obviously, the problem with that is that our health and social care systems are not set up to deal with that increase. This graph is the proportion of the population who are over the age of 65 across the world, and you can see it's increasing as we go along. So our health and social care systems aren't necessarily set up. What often happens, particularly in our media, is there's this us versus them mentality for older adults. This idea that older adults are a burden on society, that as they need care, as they need support, as financial support for a pension, as they need more healthcare support, as they age and encounter more health issues, that is a burden on the us, i.e. the us being the rest of society. Now, what is dismissed often is the fact that older adults contribute a massive amount to society, but our data collection systems are poor. We tend to consider someone's worth based on how much they're earning or generating in society. What we don't recognise is that older adults, especially once they've gone into retirement, do a huge amount of uncompensated and unrecognised labour. They tend to do a massive amount of volunteering. They tend to do a massive amount of work in local government, in local elections, councillors, influencing change in their local area. And they also do a huge amount of care, particularly older women, do a huge amount of care both for their peers, their spouses, their children, and obviously their grandchildren as well. That's a huge part of it. So one of the things, again, this context of this idea that we've got people living longer and longer, and that's a really big problem. It's not necessarily, if we take into account the added value that people add, it's just not added in a financial way that we stereotypically think of as a way that people are contributing, because they're not contributing a paycheck. Now, behaviour gerontology, we've got more older adults, as we know, who are living longer. That means more people are needing support, and we've got a support system that's under extreme stress and isn't at the moment able to cope particularly effectively, and isn't going to as we go forward. Behaviour analysts support in areas of social significance, and I would argue this is a huge area of social significance. So for me, this is a real area that behaviour analysts need to be looking into, as in we need more of us in here doing this work because we are needed. And I can tell you that we are generally, overwhelmingly, I have been embraced with open arms. I do not face difficulties supporting people in this population, from other professionals, from carers. People are really needing the support. They just don't know it exists. So behavioural gerontology as a subspecialty of behaviour analysis, so many people tell me, actually I'll come back to that, it's people think it's a new area. It was defined, there's a few different definitions, but the definition that's often used is one by Berger and Berger in 1986. And behavioural gerontology to them is a study of how antecedent and consequent environmental events interact with the aging organism to produce behaviour. Now, the key difference with that is it's about the interaction with the aging organism. So the fact that they are aging and the way that that aging process impacts on that those environmental contingencies. So that is the key difference for me. In a nutshell, it's EABA with older adults, but it's about taking that understanding of aging and what that means behaviourally into our conceptualisation and our framework. So like I said a minute ago, I got ahead of myself. People often tell me that behavioural gerontology is this new novel area of behaviour analysis. People have introduced me before as Zoe doing this exciting new thing where she's breaking through into a new area. And that is not the case in the slightest. Behavioural gerontology is one of the oldest areas of behaviour analysis. So just to give you a little idea, this is Ogden Lindsley, who, if you know precision teaching, yeah, he's the precision teaching guy. He was really interested in behavioural gerontology. He published this book chapter that was called Geriatric Behavioural Prosthetics, and he's talking about modifying the environment to support older adults as they age. That was in 1964. So that was really the kind of inception of this area. That's before JABA even started. It's before Beowulf and Risley. So that is really before applied behavior analysis as we know it was really established. We've got people like Margaret Boltz in 1977 talking about new approaches towards aging, a case for the operant model. She's talking about behavioral gerontology. She's talking about using it to support older adults, to improve functioning, to support as they age. And then Mr. B.F. Skinner himself in 1983 published a paper called Intellectual Self-Management in Old Age, where he was talking about how he changes the contingencies in his own life as he aged to maintain his cognitive functioning as he experienced the aging process. Many people don't know that Skinner also published a book called Enjoy Old Age in the 90s, which was all about, it was a layperson book. It's probably the easiest Skinner book that you'll ever read. That's all about how to change your life, change the things happening in your life to support your behavior, to stop you forgetting things, to continue contacting reinforcers, to maintain your skills, all this stuff. So behavioral gerontology is not new, and some of these big names were really into it. And all of these early behavioral analysts were talking about behavioral gerontology maintaining skills in older adulthood and solving the problems of older adults, continuing to contact reinforcers in typically developing older adults. I'm going to talk in a minute about how this is not really where the field has gone, and how it looks a little bit different now. I'm just going to check how our poll's doing. Has anyone answered? Oh, people are interested, and one person is working in this area. That's really exciting. Cool, thanks for answering. Whoops. So a behavioral understanding of aging, because this is what I was talking about, is the difference is we need to understand what that aging process brings to our conceptualization and our kind of behavioral formulations. So I conceptualize aging is a change in biological variables that are correlated or associated with age. So things like we're more likely to experience arthritis as we get older. We're more likely to experience vision loss. We're more likely to experience hearing loss. We're more likely to experience cognitive decline. We're more likely to have more health conditions, we're more likely to be not as fit and need support. So all of those are changes in biological variables. They're not caused by age, but they're correlated with age. You're more likely to experience them as you get older. And it's not just those biological variables, it's a change in social variables too. As we age, our environments change. The reinforcers that we used to find, or things we used to find reinforcing, may no longer, and other things may be reinforcing. The way we're treated by society changes too. Also, our context changes. We often retire. That means we've got a different kind of day-to-day life. We might lose our social contacts, our day-to-day work. We might lose some purpose in that role, but we might find it in other roles. We might have more free time. We might have grandchildren. We might have financial changes. For some people, when they retire, they are enjoying a life of wealth. For other people, they move into poverty. So there's all these other social variables. Again, they're not caused by age, but they're correlated with age, that change. So behavioral gerontologists are there to, we're looking at the environment, as any behavior analyst is, but specifically we're looking to change the environment to mitigate the negative effects of those variables that are correlated with age. So some simple examples of these. For those biological variables, it might be that we're supporting someone to wear glasses or to learn how to use their hearing aids. If they're experiencing cognitive decline, we might be putting reminders in place or systems to support them. We might be looking at supporting them to use walking aids. And obviously some of this is going to be in cooperation with other disciplines. For those social variables, which I think is often where we come in even more so, we might be looking at how we change the care environment to support someone more effectively. How do we increase the reinforcers that someone's exposed to? How do we allow them to access those reinforcers? What needs to change to support them? What enrichment is happening? How can we get engagement? How can we give them purpose back? And that's a very wishy-washy term, but I very strongly feel like one of the big things that we need is to give older adults meaningful engagement, a purpose, a reason, an identity. And that's all just social reinforcement, right? So those contingencies that give us social reinforcers. And some of these things are outside of our role and some of them are within, and we look at the ones that we can change to support someone. Now, moving on to major neurocognitive disorder, you probably know this is dementia, and I will flip-flop between using dementia because that is what I use every day clinically because everyone knows about it, and major neurocognitive disorder. So major neurocognitive disorder has been the correct term since it was changed to the DSM in 2013. So it's been there for like 13 years, but we all still say dementia. Dementia is not one thing. Major neurocognitive disorder is not one thing. It's not one condition or one diagnosis. It's actually, nobody has dementia it's a name for a collection of symptoms. So it's a collective term for a variety of different symptoms. So you would be diagnosed with a specific type. So the most common one is Alzheimer's disease. That's I think about 60% of people diagnosed will be diagnosed with Alzheimer's type. That's probably the one that whatever's happening in your brain right now, what you think of as dementia, you're probably thinking of Alzheimer's. But there are many, many others. I think there's like 100 of them. There's like vascular dementia, which is caused by kind of mini strokes in the brain. We have some of the interesting, more unusual ones like Korsakoff's, which is caused by excessive alcohol consumption. There's some caused by vitamin deficiencies. There's all sorts of different types of dementia. What makes something a major neurocognitive disorder or a dementia is that it causes a significant decline in someone's cognitive abilities. So this is things like their language, their behavior, their memory, change of behavior, executive functioning, how well they respond to the environment, and that they interfere with quality of life and their activities of daily living. Now, all of these conditions are progressive. That means that the person is going to get worse. The presentation is going to get worse. They're going to lose skills over time. We cannot stop it. There are some drugs that can slow down the progression, but every single person who has a dementia of some kind, has a major neurocognitive disorder, is going to get worse. The way that they get worse, how fast they get worse, the what happens in what order, all of that changes. and is dependent on the type that they're diagnosed with, and also the individual and their specific circumstances. So we cannot predict exactly, but we know some general trends. Now, dementia is correlated to age, but it's not a normal part of aging. Dementia is not something we all expect to have or can expect to have as we age. It is something that is pathological. It's abnormal. So that's a kind of whirlwind tour of major neurocognitive disorder. And this is the area that I kind of specialize in. This is the group of individuals that I really love working with. The question that I get asked all the time is, can you still use EABA with older adults with dementia? And my answer is overwhelmingly yes. The behaviour of people with dementia is still sensitive to the environment. We have a number of both experimental studies and also clinical work that shows that the behaviour of people with dementia is still sensitive to the contingencies around them. So yes, we can. But I will caveat that in the fact that dementia, I think, acts as a setting event. It changes the way that somebody interacts with their environment. So yes, they're still sensitive to the environment, but maybe not in the way that they previously were. In a nutshell, the way that I conceptualize major neurocognitive disorder is that it affects stimulus control. It affects the way that somebody responds to the stimuli in their environment. So if you think about stimulus control, there's something present in the environment that signals that reinforcement is available. You engage in behavior, you access that reinforcer. With someone with dementia, it all goes a bit squiffy, for want of a better word. So the person, their stimulus might still be there, but the person doesn't respond to it in the way that they previously would, or they respond to stimuli that they never would before in a different way. So a couple of examples, like memory. I conceptualize memory as a private event. Remembering behavior is as a private event, so it's within the skin, and it's where you arrange your private events, your contingencies, to evoke certain behaviors. So I'm remembering that I went on holiday last year and what I did. I'm arranging the contingencies to evoke certain private events. And obviously we know that lots of people, especially with Alzheimer's, can have memory loss. So there's a change in that stimulus control. If we think about wayfinding, so finding your way around, often many people with certain dementias can get lost. And again, this is stimulus control, following a path. So I see that the door's there, I go through it, I know that I need to turn left. So when I see that, I turn left. Now that I have dementia, I turn right, or I get lost and I'm not able to follow those that route because I'm not responding to the stimuli in the environment as I previously would. Or confusion, again, a really common term that we see in dementia. To me, again, that is all private events and verbal behavior. How do we know someone's confused? Because their verbal behavior in response to my questions is not related, right? If I'm doing an intraverbal, I'm saying, where do you live? And they tell me the pig is named Henry, then I know that is not, it's not the right response, right? That interverbal is not right. So there's something stimulus control wise, their behavior is not under the stimulus control of what I've asked. So that is in a nutshell. I mean, I could talk about this forever and ever, but that is in a nutshell how I approach working with older adults with dementia, with this understanding that something's happened with stimulus control. So how can behavioural analysts help? And this is where I'm going to give you some examples. But before I do, I'm going to have a quick drink. So, talking about maintenance of skills. I think this is an area that's so underdone. And you remember before, this was always where those early behavioural gerontologists said the field really should be going, what we should be doing. So think about, we know that people are going to experience loss of skills over time. That is what happens in dementia. So we could be looking to help someone maintain their ability to tact family members' names. I have a colleague who's done this over in Iceland. We can be looking at maintaining self-care skills. People overwhelmingly do not want care. They do not want to move into a care setting. They want to remain at home for as long as possible. If we can maintain those self-care skills, we can keep them there for as long as possible. That's meaningful for them. It also reduces the pressure on our health and social care systems to support them. And also the maintenance of cognitive function. If we can keep somebody able to remember to go to their appointments, remember to feed the dog, remember how to cook themselves food, actually we can keep them, again, home for longer, keep them supported, keep their dignity for longer as well. The problem is with maintenance of skills, there's no problem there. So nobody calls in a behavioural analyst when there's no problem yet. We tend to get called in when there is a problem, which I'll talk about later. This proactive preventative work, we just aren't known for yet. And people kind of almost want to put their head in the sand. I haven't got any problems yet, so I don't need any help. A little example of this, a study that we published last year, so actually myself and Carola. So this is a piece of work that I did with a lady who had Alzheimer's disease. She was living in the community in her home with her husband, and he was supporting her. When I started with her, she hadn't showered in about 4 months, but insisted that she did. She said, yeah, I shower a couple of times a week. Of course I do. Yeah, I always shower. You don't need to worry about me. And if you told her to shower, she'd go, I'm going to. Leave me alone. Don't tell me what to do. I'm a grown-up, which, of course, nobody tells me to shower in the morning. I just know I'm going to do it. Obviously, the problem was that she wasn't. So I introduced a really simple, subtle prompt where her husband didn't directly tell her to shower, because that did not work. He didn't even imply that she wasn't going to shower. He simply set up the contingencies with a verbal prompt where he would ask to check whether the pipes were working in the bathroom before she got in. So we'd go in and turn the shower on and be like, yeah, okay, it's working. It was being funny this morning, so I just wanted to check that it's not going to play up for you. And she was fine with that. He'd then go, and you know what? This morning I nearly slipped on this floor. It's like a death trap in here. It's really slippy. Can I help you in? Because otherwise, if you slipped, I wouldn't forgive myself. So at no point did he imply that she wasn't about to get in that shower. And at no point did he accuse her of anything. But he then helped her into the shower, and we got her in the shower. And then we supported her with like shampooing her hair by saying, instead of saying, don't forget to shampoo your hair, which would go, of course I'm going to, and then wouldn't. Instead, we say, have you tried this new one? It smells really good. This one's got passion fruit in it. Try it. See what you think. And would hold it out, and she would put her hand out, get the shampoo, and then naturally continue that chain of behavior. So what I like about this, and you can see from the graph in that baseline, we have zero showering behaviors. We then I did a least to most prompting procedure. He stopped taking data and stopped implementing it because it was a bit too tricky. I spent some time with him. We made a much simpler most to least prompting procedure, and that's when he started doing it more consistently, and we got that 1 to 2 showers a week, which was our goal. I faded my support, and we actually maintained this behavior for quite a few months afterwards, which was really positive because we don't have much maintenance data. And I think maintenance is even more important in behavioral gerontology because we know people are going to lose skills. We don't assume that they're going to continue with them. So the fact that we got maintenance data was fantastic. But the most important thing about this study is that it preserved her dignity. I actually never went in that bathroom with her because that would have been weird. She would have kicked me out. I never went in the bathroom with her. It was all with her husband and with no accusation that she was not going to shower. So we still managed to increase showering, preserved her dignity, and she still maintained her dignity in that she was showering and she could state that she was showering. So that's just an example of how we can maintain behaviors that are just starting to be lost. Another really important area for older adults with dementia is engagement. In older adult care settings, the amount of time that people spend doing nothing is huge. Up to 90% of the day, people are spent just sat, unengaged, doing nothing. And we know that if you're not using skills, you start to lose them more rapidly. You also aren't contacting reinforcers, and that can lead to depression and poor mental health, and also increased behavioural issues because people are bored, right? They're making their own fun, as I say. And I think this is also an area that's quite underrepresented in the literature. But I wanted to give you an example of a piece of work that was done in this area as well. So this is from Sharp and colleagues in 2019. And this was a dementia ward in a hospital setting where it was a ward in that people went for assessment generally because of their behavioural concerns, not for health reasons. Health behaviours counted as a health concern in the UK. It's very strange. So this was the ward, and what tends to happen in dementia care settings is all the chairs are placed on the outside of a room, all facing inwards, almost like a doctor's waiting room. What that does is changes the stimulus control so that nobody can see each other, no one's facing each other to talk to each other. And so what they did was looked at how they could rearrange the furniture. So really simple antecedent intervention. They clustered the furniture either around tables with activities or around kind of small groups so that people could see each other and talk to each other. And lo and behold, when they did that, when they clustered it around activities, the amount of time that people were spent in activities increased, the amount of time they were talking to each other increased as well. And when they clustered it where people could see each other, that one was the one that increased the most. People were engaging with each other and doing activities a little bit less, but still doing more. So again, this is like a super simple intervention. Doesn't require any maintenance from staff, the staff to remember to do anything, but it makes a huge difference to how we're maintaining behaviours. And so we can keep those behaviours for longer. And getting people engaged, right? Another area that we don't do a lot of is teaching new skills. And this is because it's not always needed. Now, when you're working with another population like kids with autism or people with disabilities, there's generally always more things that you could be looking to teach, right? You're always thinking that you're seeing areas where they might benefit from learning more, and we're teaching. The people that I'm working with as adults with dementia have already got all the skills they need. They've lived their whole life effectively as an adult with a full repertoire of behaviours. They've got a lifetime of experience. They do not need to learn anything new unless they have had something introduced because of the aging process or their cognitive decline or whatever it is. So, for example, we might need to support someone to take their new medication, a new medication routine, or injections, or blood tests for diabetes. We might need a new exercise regime if they have become a wheelchair user. Do they need to learn how to do wheelchair exercises? Do they need to learn how to use prosthetic aids? So I'm talking about like walking frames or hearing aids. In that case, we can really come in handy in teaching those new, the use of those things. Or new environments, so they move into somewhere and they need support in learning their way around, learning how to navigate this new environment. I think we could also use it in things like teaching digital skills, helping people who want to return to employment, helping people to manage changes in their life, things like that. I actually spoke with a student recently who just done a fantastic project where she was teaching, this wasn't people with dementia, but she was teaching older adults how to recognize potential scam messages on their phone. And I just thought, oh my goodness, that's the most socially valid study I've heard in a long time. Like, that's really needed. So this is an area that we don't do a lot of, but I think we could probably do more. Yeah, it's an interesting one. And then this is the biggie: reducing distress behaviours. So in the world of dementia, they're called BPSDs, so behavioural and psychological symptoms of dementia. Essentially, we're talking about behaviours of concern, distress behaviours, challenging behaviours, whatever phrase you want to call it. This is what we're talking about. And over the last few decades, this is where the literature has really become heavily focused. And that's great in that we've got some really interesting studies, but obviously it does mean, I think, that we're missing some of this really interesting preventative work with people with no diagnosis, or teaching new skills or maintaining, that we're really missing out on. But there has been some really interesting work done. And I was thinking about which study, because I had a range of them to pick from for this. And I thought I'm going to highlight a study by John Baker and colleagues. So this is in 2006. And I will talk you through it because I know the graph's a little bit scary when you first look at it. But essentially, this is a lady with dementia who was hitting out. They did a setting analysis and determined that the hitting was really happening in the bathroom routine. What they then did is a functional analysis and found out that basically the reason for it was because she didn't like the bathroom routine and she was hitting staff to get them to stop, or at least to pause briefly while they dealt with her hitting, so they didn't do the routine. So what they did is, instead of doing something like, in the autism world, I think what you'd be doing is teaching like functional communication, right? You'd be teaching them to say, I need a break. In this situation, there's often no point in teaching something new because someone's probably going to lose those skills. So instead, they introduced non-contingent escape. So every certain amount of time period, they gave her a break without her having to ask or do anything. They just gave her a little break and then went back to it again a short time later. And that, you can see, really reduced this behavior down. They actually did a really cool reversal design, so where they reinforced hitting with escape, and you can see that behavior jumps up, and then went back to non-contingent escape. So this is a beautiful study showing really strong experimental control. But what I like about this study in particular was, I don't know if you can see at the bottom those little round dots. Now, this is medication. This is treatment of, it's a medication prescribed for reducing aggression. And older adults are massively overprescribed medications to reduce their behavioural concerns. The amount of antipsychotics that get prescribed is huge. And obviously these people that are medically fragile, so it can cause a lot more problems than the good it does. Now, you can see she was given that every single day, and then they stopped it in the function analysis. And there is no big jump in the rates of behaviour when they stop that medication, which clearly to me shows that medication was not effective in reducing the problem behaviour, but changing the contingencies what was. So what I really like is the fact that this is kind of showing that we can reduce the need that people need pharmacological interventions, or pharmacological interventions are used by using these behavioural interventions. And those pharmacological interventions can have really serious impacts as well. So there's just a few examples. I'm just going to talk very briefly about how it's different. So especially as someone who's worked in the kids with autism world, and is working with older adults now with dementia, and I also work with adults with disabilities. One of the big things, as you know, is, as I've talked about, is it's a progressive illness. People will get worse. When you're working with a kid with autism, you are expecting them to generally get better. There's an upwards trend over time. You might see dips, you might see slight regressions over time, but generally we're expecting them to get better and maintain those skills. With adults with dementia, even if their environment is stellar, we're going to see a downwards progression. My job as a behavioural analyst is to take that downwards progression and just try and reduce the steepness. It's to try and keep it as long as possible. But obviously, as a practitioner, I also have to be aware that people that I work with are gonna get worse, and they are also eventually going to die, right? So that's a very different way of working. I'm trying to slow down things rather than teach things. Like I said before, I'm often not teaching new skills. I'm often not doing reinforcement-based interventions. I am prioritizing evoking the skills they've already got in their behavioral repertoire. I'm changing the saliency of stimuli to evoke behaviors that they've still got that aren't being evoked, or changing the saliency to reduce the amount that certain behaviors are evoked by the stimuli in the environment. People that I work with also have a long learning history. Some people that I work with have a 70, 80, 90-year learning history. If you think it's hard to change the behavior of a kid with autism who's been doing this behavior for 5 years, I challenge you to change the behavior of somebody with dementia who's been doing it for 85 years. Also, that means that I sometimes have to say, I'm not going to be able to change this behavior in a week, 2 weeks. So sometimes what I have to do is just mitigate the risk of that behavior, particularly when it's a protective behavior. Like if someone gets in the shower with me, a stranger, I'm going to kick off. It's pretty normal for an adult with dementia to do that as well. Just because they've got dementia and they don't understand they need care doesn't mean they're not going to react in the same way. They're often medically fragile, as I've talked about. So often if I'm doing an intervention and it's going really well, or we're just about to do it, and then suddenly someone has a stroke, and that intervention is no longer needed because we're not seeing the behavior because they've no longer got the capability physically, or it might have been something that affected their brain. They've now got a brain injury post-stroke. This is a very medically fragile group, and that medical understanding has to come into play in my behavioural work. The thing that I love about working with older adults is they have generally intact social repertoires. What I mean by that is they know when you're being weird. They know when you're up to something, and they will call you out. I have tried to do functionalities where people with dementia, they might not know what day it is or where they are, but they say to me, why are you being weird? Why have you changed what you're doing? If you're going to be like this, I'm going to leave. And they've walked out of the room. People with dementia are still sensitive to what you're doing, to your body language, just as much as a person without dementia is. So that makes our work even more challenging, and I have to be extra mindful of how I'm interacting with someone to make sure that it is really subtle and I'm not making I'm not coming across as artificial. And again, older adults are people that have lived their whole lives without needing much support. They have not been in care before, generally. They have not needed other people helping them to dress, to shower, to pay their bills, to remember to do things. So they're often quite reluctant and resistant to support, to oversight. They're not used to people watching. And that can make it hard from a data collection point of view. Because if I go there and watch, they're going to behave differently because they're not used to being watched. And they know that I'm watching them, and they'll tell me, why you're watching me, you're being a weird stalker. So all of those things make this work, I think, really interesting, really intellectually challenging, but it is quite different to other areas. Now, for the last few minutes, I'm going to talk for a few minutes about people with intellectual disabilities. So as we know, healthcare and care in general is getting better for the general population, but also for people with intellectual disabilities. And as those individuals get better healthcare, better support, they're living longer and longer, which is fantastic. There's also treatments available for things. So people with Down syndrome, I think it's about roughly 50% are born with heart defects that require surgery. 50, 60 years ago, we weren't able to detect those before birth, and therefore that 50% often passed away at a very young age. Now that we can detect it, they can get early heart surgery when they're babies, and therefore they're living for much longer. So what we're seeing is more people with intellectual disabilities living into older adults, more people with Down syndrome, and that means they're more likely to develop dementia as well. There is a slightly higher rate in that group of individuals of developing dementia than the rest of the population. But people with Down syndrome are an exceptional case. There is a special case. They are more likely that they show signs of aging at a much earlier age. If you've worked with people with Down syndrome, you will know that they tend to start showing signs of aging in their 30s, 40s, and that also applies to dementia. So they often start to show signs of dementia in kind of 20, 10, 15, 20, sometimes more years earlier than people without Down syndrome. Our literature is lacking in behaviour analysis. We don't have much work with this population. I'm going to give you one example now, and then we'll talk about how we can adapt our practice as behaviour analysts. So this is an example from Feliciano and colleagues in 2009. So this is a lady with an intellectual disability. She was 53 years old, and she had bipolar disorder and probable dementia. Sometimes it's harder to diagnose dementia in people with intellectual disabilities, and therefore often we get a probable diagnosis if everything looks like it, but they can't be 100% sure because the measures aren't great. So this lady was entering a dangerous staff area. Staff were redirecting her away. They couldn't stop that for safety reasons. But what they did in this situation is they introduced a visual barrier over the door. So I think it was just a piece of fabric laid over the door and the door handle. And as you can see, when they use that visual barrier with the redirection, if she did approach because they had to keep her safe, that rate of behaviour dropped massively. And again, this is stimulus control, right? We're changing the stimulus conditions that will lead into that behaviour, i.e. if she can't see the door handle clearly, she's less likely to approach and try to exit. And then they did fade that. They reversed back to redirection only, saw an increase in behaviour, and then faded the size of the visual barrier down to, I think it was 25 centimetres. So again, this is a really nice example of a simple antecedent intervention where we're changing the saliency of stimuli in the environment to make it less salient and to reduce the rates of a behaviour. So the very last thing I want to talk about is how we as behaviouralists can adapt our practice to work with adults with intellectual disabilities and dementia. The first thing to know is if you are working with someone who is 30 plus, especially if they've got Down syndrome and they're 30 plus, and you see a sudden increase in epilepsy, either they didn't have epilepsy before and they suddenly start having epileptic seizures, or if they had epilepsy but they're just suddenly seeing an increase, that is one of the biggest indicators that someone is developing dementia. And so if you see that, you want to get someone referred as soon as possible. Now, every person, particularly those with Down syndrome, should have some baseline monitoring, a baseline assessment of their skills, of their abilities. Generally, the recommendation is around the age of 30. What that does is it shows, okay, we're expecting someone by the age of 30 has learned most of the things they're going to learn. If we have that, it tells us that if in the future, in 10 years, we see they suddenly can't do this, 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 and this, we compare it and we can say, oh, actually, yes, there's been a change. Especially in care settings where staff change, there's no institutional memory of these skills. That baseline monitoring, that baseline assessment is really important. However, in the UK, that's done by the health service, but not consistently and not to the degree that we would do it. Behaviour analysts we're really good at tracking behaviour. We should also be tracking things like skill maintenance, the reinforcers that someone has, their engagement, their communication, all these things. If we can get a baseline measure, that helps massively if we see a decline in some of those areas in the future. Wherever possible, if you have a client where you see that, advocate for diagnosis, because it opens up a lot of support from other avenues and a lot of explanation as well. If we do have someone with a suspected or a diagnosis of dementia, then as I've talked about, we need to change our interventions, reduce the use of reinforcement-based interventions. We still want lots of antecedent MO interventions where we're providing lots of reinforcers, non-contingently access to things, but we're not looking to differentially reinforce behaviours. What we're looking to do is change antecedents to evoke behaviours that we want and reduce the occurrence of behaviours that we don't want to see. And then as someone progresses, because we know that someone eventually with dementia will get to the point where they aren't able to do any of their own self-care. Often they start being unable to eat, to drink in the later stages. They stop being able to communicate. And so as someone's dementia progresses, change activities and the way that we support to make sure that the options are no failure. We don't want someone to feel like they're not able to do things. And then also be really mindful that we need to support families through a grieving process. And this is hard because that grieving process starts at diagnosis, not when the person passes away. It is really hard to be grieving someone who's still right in front of you, but you're grieving the person that they were, the behaviours that they used to be able to do that they no longer can, the fact that they can no longer recognise you, even though you've spent 30 years loving them. And that's a really hard process. And as behaviour analysts, we are there. We need to support their families, their carers, their loved ones to help them through that process as well. So a very quick summary. I've talked a little about ageism, how our culture treats older adults. I've talked about behavioural gerontology, how we mitigate variables to improve quality of life. I've talked about major neurocognitive disorders, how we're looking at stimulus control from a behavioural perspective. I've given you some examples, noted how the fact that reducing pump behaviours has kind of become overrepresented in our literature. I've kind of talked about what makes older adults with dementia unique. And then I've talked about older adults with intellectual disabilities. They're more likely to develop dementia, but we are really well placed to support those individuals with recognising the symptoms, advocating for diagnosis, and then adapting our interventions accordingly. So that is everything for me. I will go and look at the questions now. If you want to follow me, there's the link to my website there. I will also put a plug in. The BG-SIG is amazing. Behavioural Gerontology Special Interest Group. We have loads of resources. There's loads of CUs as your membership, and you get access to networking events with behavioural gerontologists around the world. And if you like hearing me ramble on, then I also have social medias that you can follow there. And I will shut up now.
Well, so thank you so much. That was amazing. So I really enjoyed that, and there was so much new things. Although we've worked together before, I just I learn every time. Every time you speak, I learn from you. So that's wonderful. We have some questions for you. For instance, Maria was asking, what is the first step to get into gerontology? Assuming Maria is obviously a behavior analyst. So what would you need to do to get into behavior analysis?
I would say this is the number one question that I get asked all the time. And the problem is there's no set route into behavioral gerontology. In a nutshell, my advice would be get some training in gerontology, because there's so much to learn about older adults that doesn't include the behavioral side, but you need that knowledge. And then you definitely need some supervision from experienced behavioral gerontologists, because, like I say, it is very different working with this population. And if you've worked with other populations, there's a lot of unlearning to do as well. The approach that we use with kids and with adults can be really detrimental when we use it with older adults. So yeah, I think go and do loads of learning, loads of CEUs, go and get some gerontology training, supervision from a behavioural gerontologist, and then obviously I'm going to say again, join the BG SIG, because we've got loads of that.
Lots of work to do anyways, because as you started saying in your introduction, we're all gonna, with a bit of luck, we'll all end up getting older.
Absolutely.
Yeah. George is asking, first of all, he's saying, thank you very much for the session. I'm really interested in the overlap between recreation therapy and EABA for older adults with major neurocognitive disorder, especially when we talk about engagement. Recreation therapy brings in meaningful leisure and quality of life, while EABA gives us tools to define, measure, and support observable engagement. How do you see these two areas working together, and what should behavior analysts avoid oversimplifying when supporting engagement in older adult care?
So recreational therapy, I think, is right up our alley. I think it's also a really good role, again, if you want to go into this area. Training as a recreational therapist is a great idea. I know other behaviour analysts have gone into work in this area by going in the UK, we tend to call them activities coordinators. And so that's a really good route in. Those two areas work really well together. I think the difference is that recreational therapy is almost all of that antecedent intervention, but there's none of the analysis side of things. And I think that's what makes us different. Often the things that we're suggesting are exactly the same, but behavior analysis goes into the analyzing side of things, that makes it a little bit more detailed and obviously a different area of work. And then what was the second question? How do you say what should behavior analysts
oversimplifying? What should behavior analysts avoid oversimplifying when supporting engagement in older adults?
I probably don't fully understand this question. What should we avoid oversimplifying? I would probably say we need to avoid going straight in with a behavioural approach, which might sound really strange. But when I see an older adult engaging in a behaviour, the first thing that I think of is medical issues. I look at health, and we should do that with every population, but overwhelmingly, I do not go in and take ABC data without looking at health first, because that is, in the vast majority of cases, there's a health reason or a health variable influence in behaviour. So I would say a very easy pit to fall into is oversimplifying behaviour to be just about behaviour and contingencies, as opposed to looking at the kind of internal contingencies that are affecting it. I don't know if that answers the question.
Yeah, I think the physical factors of ill health are really important, but we do define behavior as the interaction of the organism, the physical organism, with the environment. So, as you say, we should never neglect looking at the physical organism.
Absolutely.
And how that interaction and how illness or some other accident or something influences how we interact with the environment at all ages. Because I mean, when you talk about toileting, you need to first of all, in young children, you need to first of all make sure that there's no physical reason why they can't or why they do whatever they do. There's no point in going in as a behavior analyst and sort of saying, well, I can deal with that behavior. But there's actually a physical reason why they're doing it.
And I've seen older adults who are spitting at staff, and when you look at the medication and change their medication, you realise that the spitting was because it was a side effect of one of the medications they were on, causing excess saliva. And yeah, they were a bit grumbly with staff because they didn't want the care in the way that the staff was presenting it. But the spitting was because they've got excess saliva and it's a good way of getting rid of it. So little things like that can make a huge difference, looking at the medication and understanding it as well, enough to be able to question it as a behavioural analyst.
Yeah, I think that's probably one of the difficult ones, to actually understand what the medication does. You need to nearly talk to the physicians.
I do a lot of work with psychiatrists, older adult psychiatry, older adult geriatricians. It's really important that we actually work really, in my experience, we work quite harmoniously because we have the same agenda. They do not want to be putting them on more medications, but they are seen as the first resort when they really should be the last resort.
Yeah. We have one more question, and I think it's a personal question for me because I'm so involved with the anti-EABA sentiment within the autism world. Do you see there's any anti-EABA rhetoric in gerontology?
No. It's really refreshing. It really surprised me when I came from autism and went into gerontology. I almost went in, well, I did go in ready to fight my corner, ready to justify everything. And what I got with people going, yeah, come in. Yeah, wow. We're open to it. Yeah, don't tell me anymore. Just come and do stuff. Come and help. Anything you can help. What I do find really interesting is that in my clinical work, I've never had anything. And I've talked to people from all different disciplines, across different areas, social workers, healthcare workers, and I have never had anything. But I do get it on social media where I get people shouting at me that I'm a child abuser. And I'm like, I don't even work with kids. Because the assumption is that if you're a behavioural analyst, you must work with children. And we don't get that in behavioural gerontology, at least not to my experience. Overwhelmingly, we are embraced with open arms. People are really open to it. And I think part of it is that anti-EABA sentiment around you're trying to make someone not autistic, right? Is one of those big arguments that autistic people, I don't want to get into all those arguments now, but people don't have that opinion in dementia. Nobody's saying, don't take away, we don't want them to be demented. No one says that. People don't want people to have dementia. So anything we can do to reduce the behavioural symptoms of dementia, or the behaviours that we see that are influenced by someone's dementia diagnosis, people are willing to have that happen as long as it's positive in nature, which of course it always is. People are always open to
it. I'm just Josh is just pointing out here that Dr. Rebecca Sharp has the same sentiment about seeing little or no rhetoric about EABA being abusive on in this subfield. So that's very refreshing, because in both cases, whether you work with kids with autism or you work with adults with cognitive disabilities, it's about skills development. Ultimately, what you've described, it's either bringing the skills that they have into the right context and reinvigorating them, or in some contexts teaching new skills. And it's not about changing the person, other than before that they were a person who couldn't do that. Now they're a person that can do that. And that's really the only change of. If that's a change of the person, I mean, sorry, but I'm a person who can't play the piano. If I go to have piano lessons, I'm a person who can't play piano. I'm still the same person, only a bit more proud of myself, maybe.
I think the biggest risk in behavioural gerontology is not around that rhetoric. It's actually, I think, people with little training or experience moving into the area and doing a bad job. That's my biggest concern, that we have a real duty to do a good job, and to make sure that people who move into the area and start working with older adults are really trained well, because there is so much to learn. There is so much that's different. There is it's just a whole different group. It's like I always say it's like if you had a behaviour analyst who said, yeah, I can work with kids with autism, I'm going to come in, and had no understanding of self-stimulatory behaviours, or kid was hand flapping, and they're like, what are they doing? That's strange. Oh, they need that to regulate. Like, that's weird. Why are they doing that? You'd be
Stop
like,
that.
what are you talking about? Like, that you would really worry you.
It's really interesting because all of those fields are clearly within the scope of practice of behavior analysis, but they are maybe not in the scope of competence.
Yes.
And that difference is an important one to notice.
Definitely.
But when you sort of say, well, I'm a behavior analyst, any behavior will do. I can work with all behaviors. Well, that's your scope of practice, and yeah, fair enough. But you need to be competent in your particular field.
100%.
And that's why it was nice to see some questions about how do you get into it, where do you train, how do you get training? And your talk really pointed out the quite significant difference in the whole approach, which I think is fascinating, and people are maybe not just so aware of it. I've certainly learned a lot today. So thank you so much. Our time is up, and it was just delightful to have you here, and hopefully we'll see plenty of you again. This talk is recorded and will be available for people to review, and anybody it'll be available on demand at the Behaviour Live platform, and we usually also post it on, without the CEUs for viewing. But certainly, thank you so much, and wish you all the very best, and hopefully we'll see you soon again.
Thank you for inviting me. And yeah, thank you to everyone for your questions.
Okay. Bye, everybody. Bye.